the slides. Thank you. Good afternoon. Today is packed day actually with lectures one after the other. So my talk actually is a zoom in for a rare disease that we were involved with the Ministry of Health in a successful story, and that's the spinal muscular atrophy. You can move to the next slide, please. Next. Or is it here? Is this one? Okay, thank you. I have to have a pointer then. Okay, so spinal muscular atrophy is a monogenic autosomal recessive disease. Basically, it's a motor neuron disease. The key features of this disease is, as you can see, it's mostly a muscle disease with hypotonia, proximal motor weakness, with also sometimes tremors in the milder phenotypes. It has from type 1 to type 3, that, as I will explain later on. With the weakness, they also develop other associated system involvements with skeletal problems, scoliosis, joint contractures, which will eventually affect their ambulation. They will have weak muscles of breathing, and therefore they will have respiratory infections, recurrent aspirations, etc. And together also with the bulbar dysfunction that affects swallowing, which also will impact their breathing. Now, it's related to a mutation in the SMN1 gene on the 5q region, and deletion or absence of this gene or mutation to this gene in a homozygous or compound heterozygous state will lead to loss of this gene, which is responsible for producing a very important protein for the survival of the motor neuron. That's why it's called SMN, survival motor neuron 1. Can we move to the next, please? Oh, sorry, forgot. Well, SMA is classified clinically based on the severity of the disease, starting from type 1, which actually starts since birth with severe contractures. They're very weak and they die within the first 6 months. Type 1, the symptoms start within the first 6 months, mostly due to in the first 3 months. They do not achieve the ability to sit, and they usually die within 2 years. Maybe 8%, 0.8%, they're alive by 2 years. And type 2, the ones that manifest after 6 months, and they achieve the ability to sit but do not reach the point of walking. And then type 3 is the ones that achieve the ability of walking, but then the disease would progress. Sometimes some of them also will lose the ability to walk. All of these are progressive. Now, there is a rare type of the adult, which is a very mild one, which is related to this. Now, just a clarification, when we say spinal muscular atrophy, or the focus of our talk here is mostly the 5q related or proximal SMA, because there are other spinal muscular atrophy diseases that are not related to this gene, like the SMART1, which is, again, it's a motor neuron disease, but it usually leads to distal disease. Again, it's not part of the disease of interest that I'm talking about. Now, when we talk about the burden of disease, type 1, as I mentioned, the most severe, this is the prevalence in Saudi Arabia, 4 per 100,000. Type 2, 8 or maybe 9 per 100,000. Type 3, we don't have data. And if you compare it to other countries, you see the marked difference in prevalence compared to other countries. And this is probably related to consanguineous marriages, among other factors, maybe. The carrier frequency also is higher based on the data that we have so far in Saudi Arabia compared to other countries. The incidence is 1 in 10,000 or 10 in 100,000. One thing to highlight here is, if you can see, the prevalence is higher for the milder ones, but if you talk about incidence, actually SMA type 1 is more common. And if you look at 100 patients, 60 of them would be type 1, the rest would be between type 2 and, to a lesser number, type 3 and type 4. But because type 1, they die early on, that's why the prevalence remains for the milder phenotypes. Now, of course, the disease burden is huge simply because it's a progressive a motor disability syndrome that will then affect the quality of life dimensions. As if you look at the left box, mobility, self-care, everyday activities, pain and anxiety. Also the other element that's very important, the caregiver time spent with the child. And if you can look here, a number of them would be confined to bed. Some of them will unable to take care of themselves, dressing, undressing. Some of them unable to do the usual activities of daily living, in addition to psychological impact of this chronic disease. Now, what's not mentioned here, which is very important, is actually the impact on siblings and families, because that's something that people are sometimes forgetting about. And if you think about a family with 4, 5, 6 kids, with one child spending some time in the hospital, the mother was there, the other children are deprived from their mom, etc., etc. So it is something that is maybe sometimes not calculated put in the picture. Here, the supportive care utilization, wheelchair use, amongst, again, type 1, type 2, type 3, and then feeding tubes, spine surgery, non-invasive ventilation, and invasive ventilation. So this adds up all to the burden of disease in spinal muscular atrophy. Let alone, of course, the clinic visits and follow-ups. Now, this table, this shows you the type 1, 2, 3. I'm not going to talk about why we have this variability in phenotype, because partly due to the SMN2 copy, which is another almost identical gene which can contribute to SMN protein production. But this is just to show you the incidence is highest for type 1, and then lower for type 2, even lower for type 3, and much lower for type 1. But then the prevalence is a bit different because of the survival. It's very important to remember this, because what we encountered with, or what we've seen with the new therapies, is that they change the survival picture of type 1. So they have prolonged survival, which is a very important positive outcome in this disease. However, we are now adding disability to the dimension of care in type 1 SMA, and so we have to keep this in picture. The left the left box list, actually, it's unpublished data that we did on a group of patients that we followed it in my institute. And what we found out, and I'm not going to go in details about this, but there is a big gap between patient knowledge of the diagnosis, understanding of the requirements of care, taking the lead to provide the care needed for their child. The compliance with standard of care is so dramatically lacking in those patients. In addition to, the result is a limitation in activity and participation in those patients, which is really limiting their quality of life. Let alone the consequences of this on their nutrition, bone health, survival, pain, etc. And also, part of the standard of care that's lacking here is the lack of proper assistive devices, both at home and for mobility, caregiver support, and more importantly, the absence of good prevention programs and also early diagnosis. Again, maybe this slide repeats some of what I mentioned about the prevalence. The high prevalence is due to a high rate of for consanguinity. And in fact, from this picture depicting the picture of SMA with its impact, and also it's probably the second most common disease, inherited disease in childhood. And then with the evolution of therapy, the initiative came from Ministry of Health to start a very innovative program that incorporated the 3 innovative treatments for SMA, the nusinersen, which is intrathecal exon skipping therapy, and then the gene replacement therapy on azimnogene abibarvovich, and then lately another molecule which again acts as an exon skipper. Now, with a limited number of pediatric neurologists, limited knowledge, and the availability of these novel diseases, this brought up the National SMA program. That program started, actually it says here 2020, I think 2019. when we really started meeting, putting together guidelines, setting up the scene for this big multi-dimensional project, which then worked, as you can see here. There is a centralized approval and controlled supplies, patient education and adherence, free of charge treatment, multidisciplinary team support, outcome assessment, evidence generation. This is the cycle on which this program is based on. And from that, we really see that we were achieving value-based healthcare, which again brings the point of signal to noise. And by the way, as a side talk, when they said signal to noise, I thought must be MRI meeting, because that's the word, signal to noise. But here, I think signal is really the true value that we want to reach in this disease. And we need to define the value also as appropriate to our culture and society. Again, infrastructure and capacity building, improved disease management and health outcomes, and risk sharing and limiting uncertainties. And this is the roadmap that we went through from the kickoff meetings, the development of the project, upskilling the centers, the treatment centers, creating really a comprehensive program with coordinators, treatment coaches, training also the physiotherapists who are important for the assessment of outcome, because part of the assessment of responsiveness is based on certain scales for SMA patients. And again, you can see these dates. I'm not going to go through them, but we really evolved with over the past 3 years to a very complex and mostly automated, with a great team of support to the patient in his institute, as well as a part of the national program. And this is just the program in glimpse. The patient would go there to a center, they diagnose him, they submit the required documents, which basically is about his clinical data, outcome, baseline outcome measures, etc. This would go to the committee where they review the case based on the eligibility guidelines. If he's approved, he either goes to a green zone, which actually now is more going to be amalgamated to be just one track of those who are accepted. And if he's approved for that, he would then go to to receive the therapy and get the assessment, as well as assignment of a care coach who ensures that the patient receives the multidisciplinary requirement of the program, which includes respiratory assessment, physiotherapy assessment, the nutritional assessment, etc., as well as the periodic outcome assessment to ensure the outcome, which is at 20 months, and some of them are at 60 months, depending on the product or the treatment that he received. And then if it showed that the patient achieved the outcome goals, he would continue. If he does not achieve the goals, he would then be excluded from the program. And what this led actually is, number one, we ensure that the patient receives the appropriate care with the multidisciplinary team. We ensure that what we paid for gets a result at the end. And we also kept learning from this journey as to who really achieves best, who doesn't really achieve much. And with that, I think in a few years, we'll be able to say for sure that this group of patients, we need to attend to them more, and the other group, we need to do something else for them. And these are the therapies that are part of the program: the Spinraza or nusinersen, which is the intrathecal antisense oligonucleotide. This is the first drug approved for SMA. And then the gene replacement on azimnogene. And then the latest one is the oral therapy, the Evrysdi or the risdiplam. And again, they're all indicated for SMA. And the mechanism of action, as I mentioned, the Spinraza and the Evrysdi or the nusinersen and risdiplam work on SMN2, while the Zolgensma or the onazimnogene works on as a gene replacement. Actually, it replaces the gene through a viral vector. And this is the treatment duration: 20 months for the SMN2, and for the gene, it's 60 months. What I mean by this is that the payment although the gene therapy is a one-time injection, but the payment is given as installments based on achieved goals throughout over the years of the duration of the cycle, which is 60 months. While the nusinersen and risdiplam, the cycle is, I mean, these are medications that are given periodically. The intrathecal ones, loading a couple of doses, then every 4 months, and the other one is a medication given daily orally. Those are based on the outcome measures that are assessed periodically as well. So with these therapies, the MOH actually managed to build a very complex program. It is really amazing. We are really proud of actually to have it. Not only that, you know, it's linked reimbursement to the outcome, not only it helped in spreading the cost of therapy over a period of time and depending on the outcome achieved, but also it provided a foundation of a good care for the patient, the availability of multidisciplinary care, ensuring that the patient receives this was one of the major success issues or points here that we're really proud of. I think these are the key points from the program. These are the members of the committees. The choice of therapies, 325 registered patients. These are the workshops that were done for stakeholders and treating centers. These are the referral centers, treating centers, and then the adherence to treatment is 98% in the patients that belong to the program. 141 patients are active on treatment. I think it's more than that now, right? Yeah. 151 approved SMA patients on multiple therapy options. And finally, the registry that is really now the platform on which patients are uploaded, reviewed, discussed, approved, and then followed as part of the outcome assessment. Another good point about this program, it actually took off the shoulders of the treating physician the responsibility on deciding to treat or not to treat. You know, as a clinician, we used to face this day in, day out. You know, when a patient comes with the family struggling, they want to give any treatment. And if you see the patient is less or unlikely to respond, if you say no, you are giving him a death sentence, particularly type 1. But now, if you throw it on a group of people, at least you can blame them. So it's not me. Okay, let me move on. So moving forward, I think this program will probably have more responsibilities, more roles to do. We need to really work on the multidisciplinary team in the treating centers to engage them and put them as a very integral part, because that's one of the challenges that we are seeing. Again, the national SMA initiatives and workshops, making sure that we really capture quality outcomes, and that's either through videotaping or ensuring the certification of assessors, particularly the physiotherapists, to make sure that we are really capturing a reliable outcome. And then putting additional evaluation assessments. And I think in a couple of years, we will throw all these physiotherapy assessment tools. It will be all wearable devices that will give you outcome on those patients. And finally, additional enhancement and supporting documents. I think that's my last slide. Thank you.